So I'm delighted to be speaking with you today. I am actually speaking today on behalf of my colleague Anna Caterino, who unfortunately isn't able to be with us today. Delighted to also to be joined with our close collaborator from NHS Dorset, Morad, who's going to pick up at the end of the talk. We're going to do a bit of a tag team. And I should also say that the work I'm going to talk about was done in collaboration with York Healthcare Economics, who are a unit that specialises in healthcare economics at the University of York. So what we're going to describe to you today is some partnership work that we have done, ieso working together in our close relationship with NHS Dorset, to really think about how we can learn from the data that we get to understand the importance, and particularly we're going to talk about waiting time and clinical effectiveness within the delivery of psychological therapies. So I'm sure I don't have to persuade anybody in the audience about the importance of mental health conditions. We know they're highly prevalent. We know that prevalence is going up, particularly among young people, and that the costs are astronomical. And the way that I think about this problem is what I call the mental health iceberg. So when we think about the lack of access there is to treatment, and the fact that treatments are not as effective as they could be, we end up in this really alarming situation that for every person who is able to benefit from treatment, 9 other people are kind of left underwater. So how do we move the needle on that? How do we really try to address this problem of improving access and improving the effectiveness of the therapy that we are able to deliver? So the work that we've done on healthcare economics is really trying to understand the properties of the system that we have to give us power to advocate for more access, for using technology to develop more effective ways of providing the right treatment for each person as soon as they need it. A little bit about us as ieso. We've been working in partnership with the NHS for about 10 years. We deliver one-to-one CBT through the medium of text. So a text conversation between a trained clinician and a patient, and are able to do that in a way that's opened up access to different points of time and allows people to do that at a place that's convenient for them. Alongside that, we've built a number of AI tools to really help us understand what makes for good therapy, how to improve outcomes from therapy. And over the past decade or so, we've treated over 100,000 NHS patients and are available in a number of contracts across the UK. And the work that we're talking about today on our healthcare economics modelling came about through our partnership with Morad and his colleagues, where we wanted to take the huge benefit that we get from working within NHS Talking Therapies, that's really world-leading. And I can't emphasise how passionately I believe in what an amazing system NHS Talking Therapies is. The fact that we deliver evidence-based treatments, that we record outcomes for each patient at every point of contact is such a powerful thing. It's such an important way that we can learn from the data that we get. So we wanted to take data that we had from the patients that we had treated at ieso, and together with Dorset, look at a range of different treatment modalities. So ieso offers one type of treatment. Dorset service is broader, offering a range of different treatments at different steps of care. And the opportunity that we saw here was really to understand how patients were transitioning through treatment, what was happening to them, and what were the consequences of those things. So we set this up as a healthcare economics model. We looked at the trajectories of each patient as they moved through the Talking Therapies service, how their symptoms changed, and we classify those in terms of different severity states, and then how they move and follow through treatment across a two-year time period. We used the data that we had from ieso, we used the data that we had from Dorset, and where we couldn't get costs and estimates for things, we went to the published literature and used those data. So I'll just try and describe for you a little bit about the model that we used. It looks a bit scary on the right-hand side of my slide here. We were using a Markov model. That sounds horribly complicated. It isn't really. What we did was a patient came in with a particular severity. We modeled changes in the probability of changing the state of that severity, and then looked at how that severity responded to the treatment that was delivered, so that the patient would exit treatment at a particular severity level. And then we looked over the course of what would happen over 2 years in terms of the probability of each patient remaining in that state or transitioning to other states of severity. And each of those severities were associated with costs, both in terms of how much it would cost to treat somebody, how much background medical costs they would incur, so use of GP services, A&E, etc., and also the quality of life that the person was experiencing. So it breaks down. The patient comes in, they start at a pre-severity level, they remain in that state until treatment is completed, and they then transition into the post-treatment state, and we look at that further change over the intervening period, and then look at what's happening with the costs through that. So to give you the nitty-gritty details, here's the table. This paper is published, so please do go and have a look at it rather than trying to scrabble to read everything that's on this slide. But what you can see is that we were able to break down for both anxiety and depression what happens in terms of the costs that are incurred, in terms of how much it costs to treat the patient, the background costs, so that's the background use of medical costs, and the loss in quality of life at different severity levels, so broken down for mild, moderate, moderately severe, and severe for depression, and mild, moderate, and severe for anxiety. And we've done, the model was constructed to make a comparison between what we do at ieso and what happens in the broader based service at Dorset. But I guess it wasn't really an exercise for us in making that direct comparison, but actually understanding the principal cost drivers that are responsible for costs within mental health care provision. So as severity goes up, the costs go up. That's perhaps not too surprising. And then when we looked at comorbidities, so long-term health conditions alongside the mental health condition that was being addressed, we also saw that costs rose for that compared with the standard service. What I'm going to show you in this next graph is how, having built that model, we were able to explore some of the properties. So we've set this model up, we've trained it on the real world healthcare data that we've got from about 27,000 people. And then we've said, what are the kind of levers that are responsible for principally driving costs within the mental health care system? So what we've done here is systematically vary treatment delays. So we've started that at the kind of baseline model of 6 months between somebody presenting for treatment and then actually completing their treatment. And then we said, what happens if that increases, or what happens if that decreases? And in this graph, what you can see is varying that time around that 6-month baseline in discrete steps of months. And I'm plotting this for the loss in quality of life, the QALY measure, as well as the costs incurred from background costs. That's in the green bars versus the yellow bars. And what we can see from this is that if we were able to shorten treatment, so from presentation to somebody exiting treatment by 3 months, that would be per patient a cost saving of about £500. So when you do that, you reduce losses in quality of life, and you also reduce the amount that somebody's making use of background medical services. The other thing that we can look at is quality. So how, if we vary the effectiveness of the treatment that we are able to provide to people, what happens to the cost? So again, similar graph here. We're looking at QALY losses and background healthcare costs as we systematically vary the effectiveness, and a reduction in effectiveness by just 10% is a loss of about £100 per person. So I'm going to switch over to Morad.
I think kind of Andrew's really summarised some of the kind of principal benefits of this work, and I guess for me, having moved from IAPT into the broader mental health landscape, this gives us a really good argument to take forward in terms of investment decisions. So some of the kind of conversations that you need to have with commissioners, or with the system, about how you're going to go about investing in services, this gives you that opportunity to actually use the same language and talk about the economic impact of talking therapies. Because one of the things that is particularly world leading around IAPT, as we know, or NHS Talking Therapies, is the fact that it is evidence-based, it's appropriately trained professionals, and it's about outcome monitoring. And one of the benefits is then to look at how this can then be applied to a population health management model, which is certainly coming over the horizon when we're thinking about transformation. And in particular, it's that line which is basically, there's a cost to not treating people as opposed to treating them.